Thank you very much. Always be happy to come back to Korea. It's always a pleasure to be here. Thank you for the invitation. So I was asked to talk about what we consider, let's say, Vienna or Europe, when we have a patient bridge to transplant. So this is my disclosure slide. So with the new mechanically assist devices, meaning the HeartMate 3, definitely long-term outcome of the VAD implantation has significantly increased. 5 years survival rates now up to more than 50%, with the good functional status of most of the patients still in NUHA 1 to 2, and with a long 6-minute walk test. So the question is, should we transplant these patients at all? And when we look, and I of course have to look and bring you the data from the US and European perspective, when are these VADs implanted today? So there has been some changes in the United States and in Europe, as you can see, based from earlier periods in the early 2010s, and now in the last periods. You can see less patients receive a permanent mechanically assist device while being on Intermax 1 crush and burn situation. And as you can see, the numbers of patients on Intermax levels 4 to 7, so not inotropic depending, is quite increasing in Europe. Maybe partly because this is in several European centers some kind of a bridge to decisions. So if patients might become transplantable on the later period and they are implanted at, let's say, in a healthier status than in other countries. However, and this is, especially in the US, significantly impacted by the change of the allocation system of hearts in the US in 2018. You can see those patients who received the permanent LVAD today in the US mainly are DT patients or destination patients, normally not being transplanted on the lung. And only a smaller part of the patients who receive a permanent VAD are bridged to candidacy or even bridged to transplant. So these are patients who are already on the waiting list but cannot wait any longer and then need a VAD to be bridged. In Europe, it's still different. There's a lot of bridge to transplantation, quite a number of bridge to candidacy, and partly bridge destination therapy is not that high percentage-wise because in several European centers, destination therapy itself is not reimbursed by the governments. So doctors have just to put VADs in and say, okay, let's bridge the decision, bridge the transplant to get around it. Although they know, due to the lack of organ donors, some of these patients never will have the chance to be transplanted. This is the ESC guidelines, which are quite overlapping with the ISHLT guidelines for indications, contraindications for transplant. And actually, every patient who really has advanced heart failure could be a potential candidate for transplant unless there are some contraindications like malignancy with poor prognosis or pharmacologically irreversible pulmonary hypertension. And already these two factors are potential factors to bridge patients to transplantation on the long run. Also, liver dysfunction, kidney dysfunction, where you could opt for combined heart, liver, or heart, kidney transplantation. And there are other, let's say, comorbidities with poor prognosis, which is very vague in the description. And of course, as you all know, psychological instability, alcohol, drug abuse, and so on and so on. So partly these are psychosocial contraindication, partly they're really medical contraindications to accept patients for transplant. And there's also the high BMI 35. We in Vienna have a lower, we have 30 BMI as an upper limit for transplanting patients. And this is also an indication for VAD implantation in the long run. And there's always the question, when is direct transplantation better or when is bridge to transplant better? And it seems, of course, if there's a potential for left ventricular recovery or a recent malignancy, of course, pulmonary hypertension and obesity, those patients receive a VAD and then later on might be transplanted at the later time point. So in Vienna, so why was a VAD implanted? Only 5% are real bridge to transplant patients of those who are later on put on the waiting list with the VAD, so we rarely lose a patient to VAD implantation who is already on the waiting list. So the therapeutic window for transplantation closes, the patients slowly deteriorate, and if we put them on high urgency and do not receive a heart fast enough, then we put VADs into them. But it's rarely the case today because our HU, high urgent system, is working quite well. Most of the patients that receive a VAD and then later become eligible for heart transplantation bridge to candidacy, it's 95%. And most of them either receive a VAD in Intermax 1 or 2, so inotropic, shock patients, a lot of these patients, we evaluate and say, can we transplant them in high urgent way, or do they have to be bridged with a permanent VAD? So part of them, well, if they have a smoking history, we more aggressively put VAD into them because we do not normally transplant active smokers. They have to be 6 months of smoke-free, and this is tested with cotinine. Another modifiable contraindications for transplant then, which is indications for VAD implantation, is if our patient has a body mass index above 30. Because we know that these patients wait a very long time for a transplant, and on the other hand, these patients gain a lot of weight and have a lot of perioperative complications, wound infections, and also have a higher risk to develop graft vasculopathy after transplantation. However, if we implant these patients a VAD due to the better quality of life, most of them even increase the weight after some weight loss in the early phase. So some of them already went to bariatric surgery, and I think the best potential future option is pharmacological options, semaglutide or tizanabine, those new drugs that reduce your weight. And I have a patient now who was she was always above 100 kilograms, and now 6 months under these drugs, she really went down to become a transplant eligible with about 65 kilograms. So amazing how these drugs partly work. One of the very important indications to put a VAD in for patients to become eligible for transplant is pulmonary hypertension. So we always measure, of course, right heart caths, and then we see if we can intervene or reduce pulmonary hypertension or the pulmonary vascular resistance. But if they still, with the use of pulmonary vasodilators, still stay above a certain threshold, like transpulmonary gradient above 15 or 3.5 Woodrow units, we know that they have a very high risk to develop right heart failure directly after transplantation. So this is when we implant VADs, and we and others have published that with the implantation of a VAD, within about 3 to 6 months, the pulmonary pressures go down, pulmonary vascular resistance goes down, and this is really helpful. And of course, patients who had cancer pretty close to, let's say, becoming a potential transplant candidate, we really put VADs into them to really give them a good chance to survive over a longer period of time and observe them if they stay cancer-free for the next 5 years and then become transplant eligible. And we have several of these patients who in the end then became transplant eligible, and we transplanted them. So these are the points where most of the VADs as a potential bridge to transplantation are implanted in Vienna and in most other European centers. Of course, the significant differences in demographics and especially blood group, which has an impact between Korea and Europe. The blood groups are totally different in the percentage. I found this very interesting topic that there is the situation of that a lot of Koreans associate blood group personality, which is totally unknown to Europe. That's very interesting. I learned a lot from that. And as you can see, there's a huge difference, especially in blood group A, B, and AB. And these patients have a benefit because they have the access to more potential organs. Only blood group O patients only can receive blood group O donor hearts, and this has an impact because of this high number. In Europe, we have very long waiting lists of these patients with blood group O. And this is also in the US the same, and this is alive, waiting and being transplanted in the US after the US allocation changed. So still blood group O has a worse chance to be transplanted and a longer time on the waiting list in Europe and the United States. And of course, this is the Eurotransplant waiting list. So after 12 months, only 37% of the transplant in Eurotransplant patients have been transplanted. About 18% have died within the first year after putting them on the list. So this is why we have to implant more VADs to help these patients. And of course, there's a significant difference in the demographics between Korea and Europe. You see the average male and the average female patients are significantly smaller and have less weight in Korea compared to Europe, lower BMI. And interesting what I found out after watching that the recipients, female and male, who wait on a cardiac transplant are quite similar in Korea and Europe, 70% to 75% male, whereas 25 to 30% female recipients. However, donors are totally different. What I saw from a donor report from Korean Transplant Society, only about 30% of the donors in Korea are female and 70% male, whereas it's 50% in Europe. And this has a huge impact because we rarely implant female hearts into male recipients because of the size and weight mismatch. And this, of course, has a benefit for females on the waiting list. However, males wait much longer because there are not enough male donors in Europe. And as you can see, this is just our today's waiting list. You can see that a lot of our patients have a VAD waiting on a transplant, and a lot of them, I can tell you, are big-sized and big weight patients. And they really wait almost forever. The bigger VAD patients, especially in blood group O, wait significantly longer than those who do not have a bigger weight or from another blood group. And if you want to receive a high urgent donor offer, and if you have a VAD implanted in Eurotransplant, there is a very clear, there are very clear rules to put patients on a high urgent situation. You have to send all the data of this patient to a blinded HU audit team, and all these complications have to show up more than 30 days after implanting the VAD, and you can either have cerebral complications, peripheral arterial embolism, treatment of refractory gastrointestinal bleeding. So classic VAD complications, but you really have to prove that this isn't just the first time. So these mostly are recurrent problems that you can put them on high urgency. So the VAD patient, in maybe contrast to some other countries, do not have a benefit or get preferential treatment on the waiting list. And in our own center, over the last 24 years, you can see the numbers of VAD patients transplanted are always around 20 to 25%, about a quarter of our patients who are transplanted are VAD patients, and now 57% of our patients are transplanted via high urgency. And this is partly due to the higher rate of ECMO bridge and impeller bridge to transplantation in our patients, where we also, similar to the US, aggressively put the patients on the waiting list. Of course, this is data from the US. After the change of the allocation, those patients who were bridged to transplantation with an LVAD, a permanent LVAD, seem to be associated with a higher stroke rate after transplant, a higher dialysis rate, but a lower rate of acute rejections after transplantation. And now, after the allocation change, longer ischemic times and a longer stay in the ICU, and there seems to be a little bit worse outcome in the US. This is your own data. This is Korean data. The thought about, so what is the optimal timing to bridge patients after heart transplantations? I can tell you in our center, those patients are put on the waiting list at the earliest 3 months after implantation of the VAD. They have to be fully rehabbed, staying home, being without any problems, and then we put them on the waiting list. However, I can tell you most of them wait for 2, 3 to up to 4 years. And the problem is, on top of that, and as I said, there might be an association of a higher rate of primary graft dysfunction. This is data from the ISHLT. The older a donor heart is and the longer the ischemic time, there is a higher risk of these patients to not survive the first year. And this is our own data in Vienna. So we have a median donor age of 44.5 years, I guess similar to Korea, a very long ischemic time. Median waiting time, median ischemic time is 4 hours. So this is an impact. We know that primary graft dysfunction is a cause for early death after transplantation. This is data from an international consortium. And besides ischemic time and donor age, permanent LVAD pre-transplant is an independent predictor of primary graft dysfunction after transplantation. So this is very important to understand. VAD transplants are more complicated than non-VAD transplants, and this is also shown in some single-center analysis. So can we protect the hearts a little bit better? New technologies, so this is data with the organ care system, so warm oxygenated blood perfusion. Still, VAD patients, two-thirds of these patients, but still a PGD rate of 16%. With a new transport device, the Shepherd Pack, there seems to be an independent benefit against severe primary graft dysfunction in VAD patients. This is only VAD patients. And this is also partly older recipients on a VAD seem to be prone to a higher rate of primary graft dysfunction. And with the newest kit on the block, we just finished and published data as a big prospective randomized study in Europe. It seemed that with cold oxygenated perfusion, this seems to be associated with a little bit lower rate of primary graft dysfunction. So there is hope out there for our VAD patients that we finally find ways that they might not be associated with higher primary graft dysfunction rate. Sensitization, we know that sensitization can develop after VAD implantation. About 40% of the sensitized patients are VAD patients. There are patients who are not sensitized pre-VAD and develop sensitization, maybe due to use of blood products, and this has an impact. What we're going to do with these patients, they might be more prone to antibody-mediated rejection, or we might need a better way. So what we do in Vienna, if we're sensitized patients, we totally do the virtual cross-match today. So we talk to our HLA lab, what are the HLA types that we can accept and what are not acceptable. So if the virtual cross-match negative, we go for the transplant. If it's positive with very high MFI, so very aggressive, normally reject the organ. In a VAD patient who has complications and high urgent, we do immunoabsorption prior to transplant, then transplant, or you can also do plasmapheresis and then start a very aggressive immunosuppressive protocol. But even in lower MFI but positive, we do the transplant and then measure donor-specific antibodies early after transplant. And if they start to rise significantly before AMR happens, we start immunoabsorption. If this all does not work, then we also put on some special antibody treatments, mainly with daratumumab. Just briefly, 2 more slides. One about HIT, heparin-induced thrombocytopenia, quite associated with after VAD implants, especially very sick patient. So there seems, this is data from Anesthesiology Journal, either cangrelor or plasma exchange seem to be beneficial to prevent HIT-induced thromboembolic events in patient undergoing cardiopulmonary bypass, including transplantation. And the question is, if you do less invasive VAD implantation, does this have an impact on post-transplant? Well, to be honest, maybe a little bit less blood product use, but the same duration of the transplant, the same ischemic times, and post-transplant adverse outcomes quite similar. So there is no benefit after transplantation in these patients. Survival seems to be a little bit less early on, long-term survival in our VAD patient. This is the Vienna cohort. However, this is also the data from the 80s and 90s, including in the last 10, 15 years. VAD patients have the same outcome in survival than our conventional transplant patients. So in summary, long-term VAD support has become significantly better with the new technologies. More DT patients, destination, still 20% patients bridge the transplant with the VAD. Long-term VAD, which means years, support is today's reality. We have the same contraindications as non-VAD patient. The question is, should we use stricter rules, lower age limit or whatever? Some patients receive a VAD due to modifiable contraindication. We have to wait until these they are gone. High urgent VAD transplant has decreased due to the better VAD technology that we're using now. VAD transplantation is associated with a higher risk of primary graft dysfunction. Maybe new preservation technologies might help. HIT and sensitization can be managed. Minimal invasive VAD implant, no longer significant impact on VAD transplant, and the outcomes of post-transplant VAD, post-transplantation with VAD are similar to non-VAD patient. Thank you very much for your attention.